several days. So I'm going to just give a couple of brief high-level remarks, and then I have members of our team here who have a PowerPoint, and then, as Lisa said, we will do some Q&A afterwards, starting with legislators and going from there. So over the last few months, my team at DHS has been working around the clock to respond to what we are now calling COVID-19. DHS is lucky to have such a skilled team working to protect Wisconsin residents. Today, Governor Evers wanted me to update all of you on COVID-19, what you need to know, what you need to be prepared for, and how we can work together to protect Wisconsin residents during this outbreak. For context, Wisconsin has had one confirmed case up to this point, to date. There's currently one person who remains under investigation, and their test is pending results. I want to reiterate that the risk to the general public remains low at this time. As the situation evolves, our guidance will evolve as well. So we ask folks to stay tuned. We update the DHS Outbreaks and Investigations page daily at 2 p.m., and we encourage you to continue to monitor it and the CDC information, the CDC website for the most accurate information. Now, as I mentioned, I'm going to turn it over to my team, to our State Health Officer, Jeanne Ayers, to our Chief Medical Officer for Communicable Diseases, Ryan Westergaard, to go into the nuts and bolts of what we're seeing here.
Thank you. Thank you, Secretary Palm. Thank you to everyone for being here. I'm happy to provide some background information about the current epidemic of COVID-19 and what our team at DHS is doing to prevent its spread in Wisconsin communities. I'll start by saying that coronaviruses in general are a large family of viruses that can cause respiratory infections in humans and other animals. Coronavirus infections are not rare. In fact, we typically see a spike in cases around this time of year. The important difference to understand is that while the seasonal coronaviruses typically cause mild upper respiratory infections, that is infections in the nose, the sinuses, and throat, the new COVID-19 virus has a tendency to cause more severe disease involving the lower respiratory tract, meaning the lungs, which this places patients at higher risk of pneumonia and sometimes severe lung injury and even death. In this respect, this novel coronavirus causing COVID-19 is similar to other novel coronaviruses that have caused important outbreaks in the past 2 decades, including the SARS coronavirus, which caused severe acute respiratory syndrome in 2003-2004, and more recently the MERS, or MERS coronavirus, which caused Middle East respiratory syndrome. When we refer to novel coronaviruses, we mean to say that this is a new species of virus that has not previously been identified in humans. The novel virus responsible for the COVID-19 epidemic first emerged in the city of Wuhan in China in December of 2019. It quickly spread throughout mainland China, where it's now caused over 80,000 confirmed cases, and subsequently to more than 50 additional countries around the world, including the United States. What all coronavirus and all respiratory viruses have in common, and this includes the influenza virus, is how they're spread from person to person. How easily a virus spreads from person to person can vary, but in general, these types of viruses spread by respiratory droplets produced when a person coughs or sneezes, or by touching a surface that has the virus on it and then touching your nose, eyes, or mouth. Symptoms of COVID-19 can include fever and difficulty breathing and cough. The symptoms can occur anywhere between 2 and 15 days after exposure to the virus. The illnesses described to date in the current epidemic have ranged widely, but many have had mild symptoms, and there's a wide range of presentations. Novel coronaviruses can be considered zoonotic infections, which means they're commonly found in animals and then can be transmitted from person to person. For example, the SARS coronavirus appears to have originated in bats, and the MERS coronavirus is transmitted by camels. That being said, the possible animal sources of the virus that causes COVID-19 has not been fully worked out, and the current risk of transmission is really primarily from person to person. Since this outbreak began, there have been more than 90,000 confirmed cases across the globe, including more than 3,000 deaths. On January 30th, the World Health Organization confirmed that the COVID-19 epidemic was a public health emergency of international concern. And the following day, U.S. Health and Human Services Secretary Ayers declared a public health emergency in the United States. The Centers for Disease Control and Prevention and our team at the Wisconsin Department of Health Services has been closely monitoring this outbreak since it began. As the Secretary mentioned, there's been one confirmed case among a Wisconsin resident who had traveled to China, which was diagnosed on February 5th. Thanks to a well-coordinated response that involved healthcare providers, local public health, and the patient, no additional infections occurred as a result of that case, that travel-associated case, and the patient has fully recovered. In the United States, as of last evening, there have been 125 cases reported. And as of this morning, 9 deaths have been reported, all in the state of Washington. This is rapidly changing. In the past week, the number of states reporting confirmed cases has grown. The current situation in Wisconsin is that we've not yet detected additional COVID-19 cases, but we're actively facilitating testing for individuals who have developed respiratory symptoms and have visited one of the growing numbers of geographic areas in the world which have sustained community transmission. It's possible, and in fact likely, that we will detect additional cases in the coming days or weeks. If and when that happens, we at DHS and all of our partners will use the same type of coordinated public health response that was used to successfully contain and prevent onward transmission in other cases, which my colleague Jeanne Ayers will describe momentarily. The evidence suggests that COVID-19 cases will continue to increase in the US and internationally, and we expect that the global situation will cross the threshold where it's likely to be considered a pandemic. Having said that, our assessment of the current situation about the immediate risk to Wisconsin residents is unchanged. At this moment, there's not evidence that the virus is circulating in Wisconsin communities, and the risk to the population is low. And related to this last point, I'd like to emphasize one main message. If and when we identify new cases of COVID-19 in Wisconsin, the strategies that we'll use to contain the epidemic and prevent widespread transmission of the infection will require true partnerships and close collaboration of the entire community. We at DHS are striving to ensure that we have effective lines of communications to all kinds of stakeholders in our communities, from individuals and families to healthcare systems, first responders, schools, businesses, churches, and everyone where people get together in congregate settings. In cooperation with these partners, we've been preparing for this type of situation for more than a decade because of the known risk of pandemic influenza. Although coronavirus is a different kind of virus than influenza, particularly because there's not an effective vaccine at this time and we don't have effective antiviral treatments, the basic infection control measures and the community-level interventions that we have in our toolkit remain highly applicable. Thanks for your attention to these remarks. I'll now like to turn it over to State Health Officer Jeanne Ayers.
Thank you, Dr. Westergaard. So I think that the point has been made that responding to an outbreak takes a broad team of people with many different players across sectors. In fact, virtually everyone has a role to play. While the public health system itself has some specific responsibilities to identify and control the outbreak, we also work with the broader public health system. And that encompasses the federal, state, and local departments of public health, hospitals, healthcare providers, long-term care facilities, emergency response system, and more. Much of the work that we do at the federal and state level is organized to support an effective local response. So local communities and local public health departments are actually on the front line of protecting and caring for the needs of the communities, of their community members. So I'm going to briefly outline some of the roles that different organizations play. I'll start with our federal partners. You hear the Centers for Disease Control and Prevention. They connect with the international community and they track conditions and risks. They provide guidance on travel, guidance on testing and quarantine and isolation, education. They educate or they engage and mobilize the public more broadly and so that people can be full and active participants in the public health emergency preparedness. Then they also study the behavior and movement of the disease at the population level. And this is actually, you probably will hear us talk about epidemiology. It's our moment in public health to say that's the study of the disease at a population level. And that's one of the skill sets and the tools that the Centers for Disease bring, and then we reinforce at the Department of Public Health, or the Division of Public Health. So that includes monitoring and detecting and investigating all the potential hazards, particularly if there are environmental, radiological, or toxic kinds of exposures. They track that, and in this case, infectious diseases. One of the other things that happened is they're very effective partners with state health departments. So when we had our first identified case, within hours, probably within an hour, we had a phone call with all the experts at the Centers for Disease Control and our local health departments and our healthcare system to strategize about what to do with that first case and how we were going to do testing. And at the end of that call, they said, how can we help? And we said, go ahead and send a team. And so we had a go team, as they call it, with 3 or 4 people here ready to help us collect specimens and to help track and coach and train our teams at the local and state department within a day. So that's the kind of interaction that goes on with federal and state. There's also a number of other federal agencies. They include the Department of Homeland Security, Global Migration, the Food and Drug Administration, the National Institutes of Allergy and Infectious Diseases, which has a role in vaccine development and treatment of respiratory illnesses. And then there's the Assistant Secretary for Preparedness and Response, or as we call it, ASPR, and they coordinate on any kind of strategic national stockpile of supplies. So I understand that Congress is currently in conversations about an emergency appropriation, and so it's possible that we will be receiving some additional support for the demands that are being put on the state and local healthcare systems and public health systems nationally. Then the Wisconsin Department of Health Services has a key role here. We overall support and enhance the capacity of state, tribal, and local health departments, as well as the healthcare system, to prepare for public health threats and emergencies. So there's the planning, there's a lot of ongoing, continual planning that goes on, and exercising and responding that goes on, when there isn't an epidemic going on. So I want to name some of the partners in Wisconsin. We have 7 regional healthcare emergency preparedness coalitions called HERCs, and they include the EMS, the Emergency Medical Service, the local health departments, law enforcement, and healthcare, and they do planning at a regional level. Then there are the Healthcare Emergency Preparedness Program. There is a system of called the Wisconsin Emergency Assistance Volunteer Registry, or Weaver, of people who volunteered to step up when there's an additional need that would occur. We have a number of communication tools. We have one called YTrack, Wisconsin Tracking Resources, Alerts, and Communication, which helps us track the availability of supplies and beds and other kinds of medical resources. We have the Partner Communications and Alerting Portal, or PCA, which is used primarily by local public health. So when we always say contact your local public health department, we are pushing out all the guidance and all the changing information to local public health through that PCA portal, so that everything is current at the same time. And of course, then we also have the Wisconsin Electronic Disease Surveillance System, or WEDS, so that we can keep track to communicate between the provider, the laboratory, and the public health system, and track the any kinds of cases that are identified. And finally, we coordinate with our colleagues at the Wisconsin Emergency Management or WEM, and they have broad emergency management responsibilities. So that's just part of the tapestry, the infrastructure around emergency response and preparedness in the state of Wisconsin that has been operating and practiced in relationship for years. Then local public health is really the first line of defense and response. They lead the local planning and coordination efforts with partners across sectors like education, healthcare, corrections, public safety, and emergency response within their jurisdictions. And then they conduct the bulk of the investigation and monitoring of the individual cases. And they take many, many calls from the public. We have our partners at the state lab, at the Wisconsin State Laboratory of Hygiene at UW-Madison. They're a critical partner for testing and monitoring the spread of the disease. And the state lab is now able to conduct testing for COVID-19. And in addition to the Wisconsin State Lab, we have the Milwaukee Health Department lab, which is now also able to conduct the testing here. And so having this expanded laboratory capability in Wisconsin provides fast access to the high-quality testing that's necessary and can help make a major difference in our ability to identify cases quickly and control spread. We had some conversation because the state lab has, just begun to do this testing this last week here in Wisconsin, and people have been using this word testing kits. And I just wanted to sort of answer a question about that, because when I go home, family members say, well, I want one of those kits. And so what I want to just mention is that these kits that have been termed that are really actually the testing reagents and tools that are used at the laboratory level. And the way the tests are actually conducted in your provider's office is with a swab that is a common tool that is there. So it's not like there is a shortage of kits everywhere across the state. This is a capacity within a laboratory. I then want to continue to stress that, as the Secretary said, the risk to the public remains low. We at DHS, the Centers for Disease Control, the local public health and tribal health partners are all working diligently to keep it that way. But as we prepare to transition from basically containment of the disease, where we're able to identify the one person and quarantine and all of that to a different level, it'll be especially important that we all do our part. So the local health providers have roles. They need to continually and routinely ask patients about their travel histories. And those travel histories aren't just about China at this point. There's keeping track of the places where there's community spread is helpful and important and can inform decisions. And again, exercise precautions within the healthcare system for respiratory illnesses. People who are experiencing symptoms should call the provider's office before they go in and share their travel history and their symptoms so that they can get specific direction on how to enter or come to the facility or if they need to. If a provider suspects a case of COVID-19, they need to work with the facility's infection prevention staff to review site-specific plans for the identification and isolation, where and what doors people will go in and what rooms they are brought to, are all parts of the facilities planning. In addition to these parts of the public health system, we also work with employers, schools, and other government agencies, the media, and the general public, because everyone has a role in preventing the spread of infectious disease, from washing your hands and not coming to work or school when you're sick, to supporting policies, workplace policies that will allow people to stay home and not spread. So I want to just mention, okay, so we talk about these different levels of preparedness. We kind of think about it in terms of three levels. Containment, which is what we've been in. This level called, containment, where we're working to contain any spread. Now, Washington State has moved beyond containment, and they have what we would call the known or suspected community spread. And then finally, there's widespread transmission. So there's like 3 levels. It's not one day you're one, and then, I mean, each one of those will require some changes in our approach. And so we're just foreshadowing that there may be moments that where we're doing some things about quarantine and being very rigid about certain ways of approaching something, which as it moves, as we have a widespread transmission, would potentially change. And so that's why keeping up on the latest guidance is so important. So here, what can you do? Respiratory disease protection. I know it sounds so simple, and people are like, we got this outbreak thing, and people are saying, wash your hands. Yes, wash your hands. It is actually one of the most effective approaches that we can take. Covering our coughs or sneezes, staying home when we're sick. I'm working really hard to change my own personal norm of not shaking hands. You can go like this, you can go like this, I don't like the fist bump thing, but you can do something else, and we can just be respectful of that, because it's an automatic sort of approach. We're working with the Centers for Disease Control and our local healthcare partners to understand any surges and demands for medical care and or supplies. We conduct extensive outreach with various organizations and reinforcing infection control principles. We have, the Centers for Disease Control is working hard and with the National Institute of Occupational Safety and Health to help identify strategies to conserve supplies, including personal protective equipment, and begin to figure out if we ended up with not enough of personal protective equipment, how would we begin to change our approaches and still provide as much protection as possible. So there's guidance that is being developed around that. And we are investigating and looking at ways to accelerate use of telehealth tools to facilitate the being able to care for people more remotely, and educating communities and families. There's more. School, there's things that might be necessary. Again, the handshaking, home isolation when sick, covering coughs and sneezes, avoiding touching our faces and eyes. That's really important. Sometimes people say, well, what about those face masks? Probably one of the most valuable parts of those little face masks is it sometimes helps people not touch their faces and eyes. So that's just something to be reminding yourself and your family members, your children about. Routine surface cleaning of frequently touched surfaces. It's possible that if there may be needs for some potential school closure or changes in approaches to mass gatherings, other ways of doing social distancing, making plans for how this is, I think, important. Make plans for how you might support your family members who may need to self-isolate because of symptoms or because they have more vulnerability. So it's not just that people who have symptoms shouldn't be necessarily out and about, but if someone has a significant vulnerability, you may need to think of how to support them in other ways with food or just getting medications and things like that. Here's something important. Take care of yourselves. Any decrease and any way to decrease the demand on the medical care system will be really important. So if you haven't had your flu shot, please get your flu shot. Get enough sleep. And think about those among us who are the most vulnerable and how we assure that those populations and people are best protected by the decisions that we make and the plans that we're putting in place with partners. Be conscious of the vulnerability, the medical vulnerabilities of others, nursing homes, assisted living, congregate living situations. Dr. Westergaard is going to talk a little bit more about one of our broader tools, and thank you for coming and for your attention and time.
Thank you, Jeanne. There are a large number of tools that we have at our disposal to respond and be prepared. The one that we wanted to mention for this audience in particular is that of public health emergency authorization. As I mentioned in my remarks, in late January, Secretary Ayers declared a public health emergency for the entire country, and that was the phase in which we were in containment mode with a number of travel-associated cases. Since that time, some additional local and state jurisdictions have declared public health emergencies for reasons related to the local context and the need for resources. Those include the states of Washington and Florida, and also the city of San Francisco. The last time that the state of Wisconsin declared a public health emergency was in response to the H1N1 influenza epidemic in 2009. Each state has a different process for declaring public health emergencies, and the tools that are unlocked or the resources after declaring emergency also vary. During a governor-declared public health emergency in Wisconsin, the state may use certain powers to address the situation. State law outlines what powers are available to the governor and DHS during such an emergency. And one of the tools would be to allow us to use state funds to support local public health department activities, particularly with regarding costs related to quarantine and isolation among people who are exposed and or infected with the disease. Well, the state has not concluded that there is a need to declare a public health emergency at this time, but it's important to know that this tool exists, and DHS and the governor's office will assess this authority if needed to protect the health of our citizens.
Again, we appreciate everyone for coming today. We will make sure to send out this slide deck to everyone so that you have links to the additional information that's on the slides right now. If you go to the DHS website, on the home page, there is a link to our COVID-19 site along with our Outbreak site, where you can track on a daily basis any updates to guidance, any information that your constituents would want to know about how to protect themselves and what to be planning for. So with that, we'd like to open it up for questions and would like to prioritize legislators and staff who have questions, and would ask that folks come up to the microphones and turn on the speaker and identify yourselves, and then we'll be glad to take some questions. If you want to come up to the microphone and turn it on, please.
Good morning. I work for Representative Jeremy Thiedsfeld, the chair of the Education Committee. This question that we're getting a lot of questions about is, what is the plan if a student or teacher tests positive, particularly K-12?
So I'll start and also introduce our team. And we didn't introduce verbally that we have our lead communicable disease epidemiologist, Tracy DeSalvo, who's with us to also answer questions that are related to local public health response and contact investigation. So I'll let others weigh in specifically, but our expectation, our understanding is that over the past decade, plans have been in place around pandemic influenza to decide what are certain thresholds for doing interventions such as dismissals, canceling activities, and closing schools. So those are sort of the extreme things that we can do, but we wouldn't necessarily do for any given case. We do that after consultation. If a specific case at this time, given this in the state of the epidemic, in a student or a teacher, we would do the same activities related to containment, understanding people who are exposed and potentially quarantining, as we would for any case, with close partnership with those agencies. Anything else that Tracy would add to that about our strategies?
I think, as Dr. Westergaard mentioned, one of the key strategies that we have when we have a case at this point in this kind of investigation is to do contact tracing and to work with individuals, to do home quarantine, to do social distancing, to do self-monitoring, and work with their local health departments to monitor themselves for symptoms of COVID-19 so that we can identify additional cases quickly and hopefully contain the spread within communities. So that would be the strategy at this point in time.
Representative Tittle?
Thank you. Representative Tittle from Manitowoc. Are you working with some of the nursing homes and some of the other facilitators that, it seems like out in the state of Washington, there was, the biggest problem was with people with compromised immune systems, compromised other health things. So are you working with them to try to better educate them as well?
Yes, thank you for that question. It's, I think, one of our areas of vulnerability for a few different reasons. We have a point person who is serving as the liaison to long-term care and to other kinds of areas where there might be congregate dining and support. So Carrie Mulkey is our director of the Bureau of Aging and Disability Resources, and she's serving in that role, and we're coordinating with the Division of Quality Assurance, which also supports and does the regulatory oversight of long-term care facilities, and are also coordinating across the department for all the different touch points that, no touch points, but all the different intersections that we can to both get words out and provide cautionary information. One of the things that we have to be conscious of is the already acute shortage of workers in these facilities. And so one of the things we really have to be, one of the things that I'm thinking a lot about is how we support facilities if their workers become ill. And so these are some of the things that we think we need to anticipate.
And Jeanne, if I can add, Jeanne talked a lot before about the things that we can do to prevent the spread of respiratory diseases now, and there are a lot of other things going around. Influenza season is still very much in full swing in Wisconsin. So it's also important for people to remember that when they're going to visit loved ones, and it is really important to go and visit your loved ones and be able to see them, but to consider what respiratory illnesses you might have currently that you could be bringing in, and how you can work to prevent spreading those illnesses that are currently circulating in Wisconsin to residents of these vulnerable facilities and people who are more vulnerable populations.
Other questions?
Hi, I'm Representative Joel Kitchens from Door County. So we're concerned about the public health impact, but there is the economic impact too. And I'm hearing a lot from the tourism industry on that and the concerns. I understand that there was a major trade show in Chicago this coming weekend that's canceled, with thousands of rooms that are canceled. So I guess they're concerned about the messaging. I know there's the governor's conference coming up on tourism, that it would be very helpful if someone could present to them, and maybe you're already planning that. But I do hope, I guess, that you're working with these other departments to deal with that issue. So you can just comment on that, I guess.
Appreciate the question, because right there is the balance, and people want to be giving good and appropriate guidance when it comes to large gatherings such as conferences. I sat with the cabinet yesterday, including our tourism secretary-designee, to talk about these very questions. And we did get a very helpful tranche of additional guidances from the CDC over the weekend. One of them was including some guidance around social gatherings. Obviously, as this situation evolves, as things change here in Wisconsin and around the country, our guidance as it relates to large gatherings could change as well. And so at the moment, there is not a reason for folks to be worried about the tourism conference, for example, here in the state of Wisconsin, but we will stay in very close touch so that we are able to evolve and be responsive to what's happening on the ground for the examples you're giving, and for other parts of the state of Wisconsin, whether it's long-term care facilities, whether it's the other stakeholders that we need to make sure we're getting the most up-to-date information and guidance to, so that we are all together doing what we need to do to protect the citizens of this state.
Hi, my name is Colin. I'm here on behalf of Senator Janet Bewley, who represents the Northwest District of Wisconsin. Senator Bewley's district has a large elderly population, and when someone in that demographic is showing respiratory symptoms, how crucial is it that they're seeking emergency medical care? What's the timeline before it becomes a critical condition? And it's a pretty isolated district, so I think these people are going to be even more hesitant, even if they're showing, some fairly severe symptoms, to be making the trip out to seek that care that they may need.
Well, I can handle the first part of that question, just sort of about the ideal timing of evaluation, and then it sounds like there's some systems issues as well that are relevant. But the respiratory illnesses that are caused by this the new coronavirus, COVID-19, are really indistinguishable from, in many cases, to the full range of respiratory viruses. So they really need to be evaluated on a case-by-case basis, and as soon as possible, because we need to put people into categories of risk to see what is the threshold for needing a higher level of care. In the community-based setting at this point, we encourage people to get thorough evaluations as soon as possible to see whether there are changes in vital signs or symptoms that require higher levels of care. If in the future there is more widespread transmission, that might change a bit to the point where we want to not transport people and we want to evaluate people remotely as best as possible. That's one of the things that Jeanne was mentioning about sort of changes over the course of the epidemic. If and when there's widespread community transmission, transporting people with infection, putting healthcare workers exposed, is not without risk. So we want to do those things carefully and plan ahead for when we're in that situation. But I think the short answer to the question is that people who have medical vulnerabilities because of their elderly or frail, or because they have chronic health conditions, or have a weak immune system, are already in a higher category of having severe disease. So evaluating them promptly to see if there's any signs that there's severe disease is important. And some of the access issues, maybe defer to someone else.
I do, I want to double down on the call first. I think that particularly for the district you're talking about, the opportunity for your community member to pick up the phone and call their doctor or call their local public health officer to have a conversation about what they're experiencing, about everything from their travel history to their symptoms will help them, will provide some comfort about what they should do next, and they can get very specific guidance for their own situation about how to handle that. But I think that call, particularly if they are having some sort of symptoms, is more protective to them, but it's also more protective to the community to make that call before they show up in the waiting room of their doctor's office or in an ER, but then they can really get specific guidance about their own situation.
Other questions from legislators or staff?
Yes, hi, my name is Nathan Butzloff. I'm with Representative Samantha Kirkman of the Kenosha area. My question is about the mechanics of the test itself. You had mentioned that it's taken with a swab. I assume that's an anterior cheek swab. Is that correct?
The recommended protocol is both. It's called a nasopharyngeal swab. So in the nose, because that's where the cells that are infected by the virus reside, and a oropharyngeal swab, or mouth. So the standard practice is a swab in both the nose and the throat.
Okay. And then now that the state has the ability, and the city of Milwaukee has the ability to process the tests locally, or in state rather, what is the timeline for that process?
Yeah, that's a good question, because it did facilitate getting results back quicker when those tests came online. I think it depends. There's the pathway of getting people seen and specimens collected and specimens transported varies a little bit, but the tests are being run every day, so it is conceivable in some cases if specimens get to the lab, we have a result the same day. Is that accurate, Tracy?
Yep, that's correct. And the state lab has a courier service that works around the state, so specimens that are going to the state lab for testing can be shipped and arrive in a timely fashion. And then once they arrive at state lab, they are working very hard to make sure that all testing gets done in 1 to 2 days.
Thank you.
I have one more. You brought up something about we are in the flu season right now. Can you talk a little bit about how much each year people, Wisconsinites, pass away due to the regular flu versus this?
Sure. So seasonal influenza, of course, every year causes significant burden of morbidity and mortality in Wisconsin, around the country, and around the world. So that's something that we, of course, don't want to forget, especially at this time of year when we are really at or approaching sort of peak influenza activity in Wisconsin. And that really does cause a significant burden on our healthcare system. So I think it's really important, and, continuing to do our respiratory protection, right? Covering coughs and sneezes, washing your hands, staying home when you're sick. These are things that can help protect against flu, against other respiratory illnesses, and, in the event that we have community spread of COVID-19, would also be protective from that.
So to give an order of magnitude of how many people pass away from influenza itself, it's I believe it's in the low 100s last year, and it was slightly lower than that. So, and the total number of cases is in the thousands to 10,000s. So nationally, the range of deaths due to influenza in a typical year goes anywhere between 40,000 to 100,000. So it's a large number of people that get affected. And that's really probably the best example of what we mean when we talk about sustained community spread of a virus. So that happens every year with influenza, where people with minimal symptoms can carry the virus, can spread it to others. So we wouldn't have the resources, it wouldn't be effective to do these maximal containment strategies of quarantine and contact tracing for influenza. What we're primarily aimed at right now is preventing getting to that phase with the new virus. That is the phase that that virus is in mainland China and South Korea and other communities. We feel like we have a path to prevent that or contain that from happening, and that's really where our focus is right now.
Other questions from legislators or staff? If not, we're happy to open it up to others in the room that have questions.
Hi, Crystal from Representative Emerson's office from the Eau Claire area. Are there additional precautions that people should be taking if they have travel plans, particularly if they're going to be flying or going through a crowded airport?
So one of the first things that people should do if they are going to be traveling, especially planning international travel, would be to check the CDC's website to see what the current travel alerts are. CDC does have level 2 and level 3 travel health alerts for countries where there is widespread community transmission, and has really specific recommendations about what people should do based on the travel alert level. At this point, there are no specific recommendations about travel within the United States. We don't generally recommend that healthy people who are traveling through airports wear masks. We don't recommend that people, need to do that on a regular basis. But it's just being conscious of your, sort of respiratory etiquette. Same thing, covering your coughs and sneezes, washing your hands, and really just trying to be polite with your respiratory etiquette, and hopefully others are doing the same.
Kimber?
Hi, Kimber with Senator Fitzgerald's office. As you're talking about the spectrum of people you've been working with, I've been wondering about the end of the cycle, i.e. coroners, medical examiners. How is the department planning to reach out to those professionals, since there's a wide variety of folks who work with the deceased among our county? Some are physicians, some are not, to ensure that once someone has passed away, we truly know what the cause was, kind of like Senator Bewley's office had mentioned. Could be regular flu, could be coronavirus. So just want to see how you're reaching out. And then one other question, as our office has met with some medical examiners around the state, they said some counties refuse to fund or are hesitant to fund autopsies, blood draws. So how do you make sure that happens so we truly have a good handle on what's going on county to county?
Well, in the emergency planning system process, the pandemic plan, there's plans that people have been putting in place all along. There is aspects to that in terms of how to respond when there are excess and many deaths, and so that's an aspect of that. So that's just the first part of that question. I don't know if so we haven't had, since we've had one case, we haven't been focused right now, but those plans are in motion, or they're part of what those HERCs are working on. They're part of the system of planning. But then I don't know if others want to say anything about the funding. I can't speak to that.
Well, I guess I could add that the diagnosis, understanding the burden or the likelihood that this is the virus that causes. I think the emphasis is on making that diagnosis early in the course of illness, so the diagnosis is fixed while people are under evaluation. There may be cases where it's not, and there is guidance from CDC that the test validated to detect the virus in people can be used post mortem Fortunately, we haven't had a lot of experience with that, but I think the suggestion of including liaison with medical examiners as an important stakeholder is a good idea, and thanks for bringing that up.
Representative Schra?
Good morning. Michael Schra, 53rd Assembly District from Oshkosh. I've got 8 correctional facilities in my district. I'm wondering if your department has coordinated at all with Department of Corrections. Many of these correctional facilities are still operating, between 15 and 30% vacancy rate. So if there was a breakout, do you guys have any specific plan to man our facilities?
So as I mentioned, I sat with the cabinet yesterday, and we talked about large gatherings and implications for tourism. We also talked about this very issue as well. I think not dissimilar to other congregate settings. We are very interested in making sure visitors, workers, others who are in contact with whether it's a correction setting, a long-term care setting, or other close quarters living situations, that we are taking this new tranche of CDC guidance that we got over the weekend and applying that at the local level and helping different constituencies in the system utilize it for their own planning and for the work that they're doing to be prepared. So Kevin Carr and I have started to have conversations about that. I know that Dr. Westergaard is in close contact with the chief medical officer for the Department of Corrections, and he may want to say more about that.
Yeah, I would say that we in the Division of Public Health have close working relationships with the Department of Corrections for areas around infection control specifically. They're not considered healthcare facilities, but they have a robust infrastructure for health screening, and infection control nurses at all their facilities in their health services unit have a network where we can disseminate best practices. So we're treating it we're really in the primary prevention. We're trying to understand that people should be prepared for contingencies of having cases. And also an issue that we raised is we really aim, we've talked about this distinction between no cases to local community spread to widespread. If local community spread happens, Wisconsin's a big enough state that it's going to be very important to know exactly where that is. And if there's a community that has a correctional facility and is spreading into the community, I think we want to be proactive in the same way that we are about skilled nursing facilities or places where the elderly and other vulnerable patients are, to make sure that we have some attention paid to exposing people in terms of visitation rules or screening like we do in health systems. So I consider incarcerated patients to be vulnerable in particular ways because of their risk of transmission within the facilities, and so we have been. That is sort of one of our important liaisons.
So then, just a follow-up question. When somebody is isolated, it sounds like it's typically about 14 days that they go into isolation. Is there another test that's done? And how long does that virus typically stay active in an individual?
So currently, with limited number of cases, when we're sort of working in this containment phase of a possible epidemic, what we're really doing is testing individual cases to see when they clear virus. And so when we then can release them from isolation. There's a lot of research that's happening now to try to determine, sort of looking at the cases that have occurred, what is the point where we would say someone is likely not shedding virus. And so I don't think that there's a really clear answer to what that end time point is at this point. And I think our strategy with that will change if we get into more of a, community spread or widespread sort of approach. We won't be able to, of course, test every individual who's positive multiple times to see when they've cleared virus. But hopefully by then we'll have a lot more information from the cases we have already seen to give people a good idea of when they are likely to be less contagious. Well, and the other thing that I can mention is that we have had one case in Wisconsin, and we did do sequential testing with that individual to determine when they were negative, and that's what had to happen in order for that individual to be released from their isolation, and that individual has tested negative and been released from isolation. And so it's data from that Wisconsin case and other cases around the country that are really helping to sort of feed into that bigger picture that I'm talking about in terms of figuring out what is sort of the overall picture of an average case in terms of the amount of time that they would shed the virus.
Happy to take questions from other stakeholders in the room if folks have any. Turn on your microphone, Helen. Thank you.
I'm Helen Mark 6 from AARP, Wisconsin. What is the chance of reinfection? Do people actually get an immunity after they have had a bout of this and are cleared?
Yeah, that's a great question. We don't know the answer. In general, respiratory viruses like influenza change over time, year to year. People can get influenza multiple times. This virus, because this is its first introduction into the population, that's an area that we'll need to figure out. There hasn't been enough time and enough data to answer that question with any certainty.
I didn't like that answer.
Well, Helen, I think that's a great point, and that is the root of the anxiety about this, right? Is because it's new, there's so much we don't know. The science is changing, and we are learning as we go, and that's why our guidance will change based on what's happening on the ground, based on what the new science and the developing science tells us. And it is why it is so important for us to be transparent and to when we know something, everybody else is going to know something, because that is how we together will work through this and do the best we can to protect the people of this state. But it is why we all feel a little bit of anxiety about this, and that is natural when you're dealing with a new disease. And so we appreciate everybody's interest in this, their patience, and working with us, bringing us good ideas, helping us think about how this is a little bit different than H1N1 and how we need to adapt the muscle and the foundation that we have in this space to be as responsive as possible moving forward. But it is going to change and it is going to evolve. And as I said, we will be as transparent as we can be about what we know and what we don't know so that we can figure it out.
Michael, I work for Senator Roth. Do we have any indication on if this is going to be seasonal like the influenza? And if so, are we going to have to worry about this coming back, next fall with the next seasonal influenza as well?
Yeah, I'm afraid that we're not going to like the answer to that question either. Is that we really don't know. The very similar viruses that I mentioned. So the SARS virus. Virologists who study and characterize viruses think they're very closely related. In fact, the name of the virus itself is essentially SARS-2 because it's on the evolutionary tree. They're sort of siblings, if not first cousins. So what happened with SARS is after the localized outbreak, when it was tamped down, it didn't come back. So we don't have circulation of that virus year to year. But the seasonal coronaviruses, and there's a family of them, we do see every year they come back. So what we truly don't know whether this will run its course and be either a low level present virus, or it's going to be something similar to influenza where it circulates every year. I guess the other thing that I mention, I guess to not be doom and gloom, is there's reason for optimism. In the level of science and innovation around this. And we of the many partners that Jeanne mentioned, we didn't really talk about the scientific community, but here in Wisconsin we have a few labs at the university who are working on some of these basic virology, therapeutics, vaccine preventiveness, and these opportunities really get everyone's attention. Some of our best minds sort of step up and work with this particular virus. So the likelihood of a vaccine candidate moving toward clinical trials in a relatively short period of time, as reported by the NIH, also gives reason for optimism. Of course, we don't have a vaccine that's effective, but the timeline in general, sometimes it's taken decades to develop vaccine, and for some viruses, we can't develop vaccines. But the scientists who study this feel fairly optimistic that this is a virus for which a vaccine could be helpful, and they're actively working on that. So hopefully that counterbalances some of the responses to these questions that we don't like, because there is a lot of uncertainty. But on the flip side, we're learning a great deal all the time.
Hi, I'm John Sauer. I represent long-term care organizations, and I'm with Leading Age Wisconsin. One of the questions we have, well, there are a number, and the broad question is the department pursuing the idea of perhaps doing some kind of informational webinar specifically for the long-term care provider community? If so, I would second the need to do that. The concerns out there are many. And there is, as you mentioned, emergency preparedness planning requirements on the books and the like. And it's one thing to move from theory to reality. And so the questions that we're getting are many, including the lack of availability of masks, and how the medical community, the long-term care community, will have access to those, or is there any priority setting? In addition, when do we go to isolation, and is there recommendations about negative pressure rooms? And if a resident is at the facility and is exhibiting those kinds of conditions that we just spoke about, are there specific precautions that you would recommend that we take even before the test would come back for determining whether or not COVID-19 exists? So, sorry for the litany of them.
I'll start, John, and then I'll let the doctors do their thing. So we did get guidance from CDC for long-term care facilities, and it has been distributed. But right, it is a framework. It's a very helpful and important guidance. But what we need is to understand of the questions you've asked, which of those are answered in the guidance, and which do we need to do more work with you on? And so as we bulk up our work in specific stakeholder spaces, that we've talked about many of them today, and we start using those framework guidances to evolve our guidance and to be responsive to what's happening on the ground here in Wisconsin, we will need to be in very close touch about that. But as a baseline, we need to find the gaps specific to Wisconsin in the CDC guidance and start driving Q&A, technical assistance towards answering those, recognizing again that as the situation on the ground here changes, we will adjust, and we will work with you all to make sure we are evolving those guidances in ways that are helpful and protective of the people of the state. But I think as a baseline, we should start with that guidance and drive from there. But
so I agree. I think to that I would add the specific topic about personal protective equipment, gowns and face masks. There's sort of agreement upon what is recommended, and very early in the experience with this, when we didn't know how lethal or how transmissible it was, the recommendation came out to really sort of do maximum, airborne isolations, like you said, negative pressure rooms, the N95 face masks, which are the higher level ones that we use for highly contagious things like tuberculosis, and that was done out of a abundance of caution, but it also sort of became the best practice. So we have some science saying that this probably makes sense. We have the reality that there's going to be situations where we have to do something less than that because of supply issues, and those are those hard case by case questions are things that the guidelines sort of can't address. So I think the idea of a webinar to hear the specific questions from stakeholders is a great idea. On our side, to be proactive, we're convening a panel of experts from various sectors in emergency medicine and preparedness and EMS and long-term care facilities to sort of, when we identify these hard questions, can we give guidance that's succinct so people feel like we're doing something that adheres to some best practice and doing things in a coordinated way. So we're doing that work now so that if there are situations where there's community spread or we get this, or we have cases in facilities and we're stretched, that we have some strategies to do in ways that make sense. Because I think the experience in Washington has been, I think they're experiencing, they had to quickly realize that they had to change from the airborne to the maximum pressure to droplet, sort of simple face mask, rather, they had to make that decision relatively quickly by necessity. And so that's probably a likely type of decision that gets made. We'd like to be proactive and think about how do we make it in the right way and give people. So we're working on that now.
And we will and can plan for a webinar within I think a week. For sure by next week we will be able to. We've just designated a point person for long-term care, and I feel like having people together on a call, raising their issues and bringing their concerns will be really critical. One of the other questions you asked was if someone is ill in the setting. One of the things right now in the guidance is don't bring them to the congregate dining. That, so I know that puts extra pressure on the staffing, but those are the kinds of, there's a lot of practical suggestions and or guidance in the documents that Secretary mentioned.
And the other thing that I'll add, I think as we are talking about, identifying the needs that facilities still have and the questions that are sort of pending, and as we're planning to do a webinar, it would be really helpful. We have an email address set up. It's dhsresponse@wi.gov, and we certainly are happy to take suggestions and questions, and that's a really great place to go to. We have a team that's going to be monitoring that, so we can make sure and get the answers out to you as we can.
That'd be especially helpful, so thank you. My final comment would be the spectrum of knowledge and expertise out there, ranges from organizations that are doing highly complex, subacute care to the less sophisticated, perhaps, 4-bed adult family home. And so the level of education, I think, is significant, but I guess my advice is we can't just assume that everyone understands and appreciates the CDC guidance, and so anything you can do would really be especially helpful. So thank you very much for your work.
Thanks.
I think we have time for one last question.
Good morning. My name is Shinya Tao on behalf of Representative Gordon Hintz. Could you comment on the cost of testing procedures for COVID-19?
Sure. So the current testing that's available in Wisconsin is available at the Wisconsin State Lab of Hygiene, which is part of the UW-Madison, and at the Milwaukee City Health Department lab. And those tests are available fee exempt. The reagents come from CDC, and so those tests are available at no cost to individuals who need them. Certainly, as commercial laboratories bring tests online and testing expands to other areas, private laboratories, then there is some cost, and I don't have specific numbers on what those costs would be. But the current testing that's available is free of charge, and the courier service to get those specimens to State Lab or Milwaukee Lab is also free of charge.
So I just want to say that's the actual test cost. It isn't necessarily the visit to the provider. That's whatever it normally is.
All right, I want to appreciate everyone for coming out today and for your interest in this topic. We will continue to be in communication with you all. If you haven't yet signed up on one of the sign-in sheets as you came in, please do so. Add your information, and we'll add you to our lists. And again, if there are questions that remain, please do send them to the DHS response at dhs.wisconsin.gov, and we will be adding answers to our frequently asked questions on our website, and also responding to those as we have guidance available. Thanks, everyone.
This program is a production of Wisconsin Eye, an independent, nonpartisan, nonprofit media network with a mission to inform, educate, and engage the citizens of Wisconsin. Wisconsin Eye is the nation's first and only independently funded state civics broadcast network, providing gavel-to-gavel access to government proceedings and events at the state capitol. Wisconsin Eye would not exist without generous donors like you. Please visit wisci.org to make a donation today.